So it's a abnormal communication. It is normally not present, whereas ASD is present in fetal circulation itself. The ostium primum, secundum, all those things, they have a normal communication to bypass the blood from right atrium to left atrium directly because the pulmonary circulation is not working in intrauterine life. Whereas the VSD is an abnormal communication between the two ventricles, and it is usually associated as a congenital problem with either trisomy or trisomy 18, 13, 21, or it may be a vectoral abnormality or charge syndrome, where the associated things are coloboma, heart defect, spinal atresia, retardation of development into very near anomalies. And as you said, these are the four varieties based on the location of the defect or the communication. It may be subarterial or outlet, can be muscular, can be inlet problem, or it can be perimembranous, out of which this membranous variety is the most frequently occurring one. Other things are all 5 to 7%, 10%. Okay? And this is what is called the Swiss cheese variety of VSD, where there is a lot of multiple muscular defects involving all components of the ventricular system. And this is the one very difficult to manage by surgery. And the pathophysiological consequences are influenced by the size. Of course, VSD size, systemic vascular resistance, pulmonary vascular resistance, and associated anomalies are the four things you have to keep in mind. Classification is based on the diameter of VSD compared to normal size of aortic valve annulus, because it is very close to aortic valve annulus, and it may be small, moderate, or large. And second classification is based on the ratio between the pulmonary flow and systemic flow. Again, it can be small, moderate, or large. Spontaneous closure of VSD occurs in about 80% of muscular defects, especially if they are small, and perimembranous defects often close spontaneously. Whereas spontaneous closure of subarterial VSDs may occur, but it is rare in inlet or malaligned defects. And large defects, if untreated, then only they develop pulmonary hypertension with pulmonary vascular obstructive disease, which eventually will cause a reversal of the shunt, which is called Eisenmenger syndrome. And all the other points we have told. Diagnosis, antenatally you can make it by ultrasound. Nowadays ultrasound will detect any congenital anomalies, and we can easily diagnose that. Auscultatory findings, there will be a pansystolic murmur, lower intensity with high pitch murmur in the upper or lower left terminal area. And there may be a precordial thrill also palpable with a normal growth and development. Child may be totally asymptomatic. Unless you auscultate and find the murmur, you cannot make out any abnormality in the child. Whereas moderate VSD, there will be a harsh pansystolic murmur in the mid-sternal border radiating to the precordial area. There may be a soft thrill with prominent RV impulse, because of the larger flow into the right ventricle. There may be less light enlargement. The RV impulse also may be palpated. And in these children only, growth and development may be affected. And signs and symptoms of congestive heart failure may be there because of the excess flow into the pulmonary circulation. And in large VSD, clinical findings identical to moderate size, but it includes a thrill at the apical impulse, thrill and hyperactive precordium, increase in intensity of S2 sound, closure of the aortic and pulmonary valve will be very loud. RV dilatation and hypertrophy will occur, and there will be features of increased pulmonary vascular resistance. And the murmur may be a decrescendo, minimal, or oxen murmur. So, based on the murmur quality itself, you can clinically diagnose the size as well as the features of the shunt. Then, special investigations we have to do are find out the oxygen saturation, which will be quite normal in patients with left to right shunt. But once it starts becoming slightly reversed, then only you get the hypoxemia. Chest X-ray may show normal size when the shunt is small, but when the shunt is large, gradually it becomes cardiomegaly with pulmonary edema features. EKG in small VSDs maybe have a normal ECG, and it may show signs of LA dilatation, LV hypertrophy, and moderate VSDs and biventricular hypertrophy in large VSDs. Now, hematology, the patients may have Eugen-Miot syndrome, may develop polycythemia, thrombocytopenia, and coagulopathy. But in small VSDs, nothing more change will be there. Echo will show pulmonary artery pressures as well as associated anomalies. And again, in small VSDs, it may all be normal. And you can do a cardiac catheterization to assess the pressures, not routinely necessary, but when performed, it will tell you about the anatomy and pulmonary vascular resistance, and its response to therapy can be assessed. That is the advantage of doing cardiac catheterization. Coming to medical management, only when there is a congestive failure, it will have an indication. Frequently prescribed diuretics, then AC inhibitors may be used to remodeling of the ventricles. Small number of children with the congestive heart system pulmonary edema may require admission, and then intravenous diuretic and inotrope may be required in them. Electrolyte imbalance should be carefully monitored and treated with special attention to patients who are on large doses of diuretics or AC inhibitors. Coming to surgical management, indications are when the medical management fails or the shunt of the defect is unlikely to close spontaneously, and if there is very close to the aortic valve leaflet prolapse or aortic insufficiency is also present, then the need. And asymptomatic older children who have a larger pulmonary flow compared to the systemic flow. So these are the 4 indications for surgery. Contraindications are patients with severe pulmonary hypertension, they may not benefit much by the surgery. So the corrective surgery is surgical fast closure of VSD, which may require cardiopulmonary bypass with a cardioplegic arrest. So you have to require a immobile standstill heart, and an incision made either through the right atrium or transatrial approach, and sometimes it may be closed through right ventriculostomy also, or pulmonary artery or infundibular openings. There are so many approaches to that. And earlier pulmonary artery banding was employed as a 2-stage procedure for allow the growth until definitive surgery and reserved for critically ill neonates. So it is done in the neonatal period with those associated with anomalies who are too ill for corrective surgery with multiple VSDs. But this is not a routine thing that is done for all cases. Then there are methods of transcatheter. You can just make a passing mention of that in the examination if this question is asked, management of VSD closure. Except that you can just give the salient features of the cardiopulmonary bypass, like what are the changes in the priming solution used, and what are the intraoperative and post-op complications which you mentioned. Other than that, you don't have to waste time writing too much elaborate answer for the cardiopulmonary bypass. And normally earlier the transcatheter closure was limited to do in a very small children because of the equipment size, which are quite huge for the small vessels of the child, even if you go through the femoral route. And then the anesthetic management of CPB for VSD closure can go over inhalation induction with fluorine, maintain with isoflurane, and analgesia with fentanyl, relaxation with panchronium, because they may have tachycardia. Sometimes the conduction defect is there in the ventricular system because the bundle of fish runs through that. So if they have a low heart rate, then you can use panchronium, which will maintain a higher heart rate. You need invasive monitoring, transesophageal echocardiography, heparin, which has to give for going before bypass, and cross-match blood should be available. You can give tranexamic acid. Mild hypothermia can be employed. And, You have to maintain the hematocrit. All these things are available in the anesthesia tutorial of the week by WFSA, which is nicely given there. And, I think Risha also has prepared only from that. And you can use modified ultrafiltration to remove the excess fluid so that the patient will not get overloaded. And severe congestive heart failure, pulmonary hypertension patients, you can go for avoid excessive myocardial depression with the volatile agent, go for balanced anesthetic technique. And you may need to use intraoperative milrinone or nitric oxide to prevent the excessive pulmonary pressures. And fast track procedure can be done for straightforward VSD closure with a still persisting left to right shunt, not in a reverse shunt. And early tracheal extubation within 4 hours can be done. And we can use high dose fentanyl 10 to 30 mics, bolus atracurium, for fast track, you have to use all these things. Local anesthetic wound infiltration and antiemetic administration to extubate the child much faster. And immediate post-op, you have to look for all the electrolyte imbalance, correct them, keep the patient, bring back the patient temperature to normal, control possible surgical bleeding sources, and combo elastography useful to guide for further protomin or product administration to treat any coagulation abnormalities after CPB. Now the complications, sometimes it may not be fully corrected. There may still be some communication between the left and right side. There may be heart block, as I told you, because it may suturing may go with the conduction pathways. Arrhythmias, especially junction electrophic tachycardia, may be there, and so these three are the major complications. And if a VSD patient who is not symptomatic or with the mild symptoms comes for a non-cardiac surgery, which is a very common thing which we see in patients with cleft lip and cleft palate. They come at the age of 3 months for cleft lip correction and 9 months for cleft palate correction. As long as the VSD is small and the shunt is still shunt left to right with no pulmonary overload, then they are very safe candidates. You can do surgeries, safe conduct of anesthesia for non-cardiac surgery. It depends on patient's clinical condition, nature of the surgical procedure, and local resources available. And the moderate to large VSDs with high pulmonary flow compared to systemic flow, with the evidences of congestive heart failure, they are the patients who will give you trouble. So long-standing uncorrected defects with pulmonary hypertension, they have a higher risk compared to the small VSD with still preserved left to right shunt. So patients with successful complete early correction of VSD can be treated as patients with a normal heart. So if already a surgery has been done and corrected, and if they come for any incidental surgery, we have to treat them as a normal patient and not to worry about that. And endocarditis prophylaxis is indicated when there is an uncorrected or residual lesion. But if it is a fully corrected lesion, there is no need for prophylaxis. And this is the shunt flow dynamics, how it goes. And this is a simple thing that you have to remember when anesthetizing patient for non-cardiac surgery. See, normally, if it is SVR should be greater than PVR. Okay? So that means if it is if the PVR becomes greater than SVR, the balance is tilted. The PVR is higher than SVR, then the shunt will happen from the pulmonary side to the left heart. So right to left shunt will come, patient will be hypoxemic. On the contrary, if SVR is higher than PVR, then the shunt will be which side? SVR higher, PVR low.
Left to right shunt.
It will be left to right shunt, and it will cause more congestion in the pulmonary circulation because more blood will be flowing towards the pulmonary vasculature. And if you have this normal PVR and slightly low SVR, what will be the condition?
The ideal flows can be explained.
Ideal flow. So normal PVR slightly low, it's ideal, and patient will have a good flow into the systemic circulation and not too much of flow into the pulmonary circulation. So our aim is to maintain normal PVR and a flow slightly lower SVR, which is ideal for management of a patient with the now coming for non-cardiac surgery. Okay. So this is the management atrial septal defect. So it's not necessary. Intravenous septal defect, major direction shunting is left to right. Minor right to left shunting can be observed. Faster developing and more pronounced effects on pulmonary vasculature compared to ASD because of the high pressures that pump the blood from left side to right side. Long-standing ESDs, pulmonary vasculature will react more and signs of pulmonary hypertension will develop early, and shunt reversal and Einstein syndrome and have an enlarged VSDs by the age of 2. And transcatheter closure, this is how it is done for perimembranous and the muscular thing. There are two different types of catheter closure. So this is called Amplager perimembranous VSD closure device, and this is the muscular VSD closure occluder or device. And the mechanism how it works is it's introduced through the opening itself, and there the expansion, then you pull it out, this comes to this side, and it is fixed with a screw. Okay? So that is how the whole device is closed with the closure mechanism. So the whole thing is done. That will be in about